Okay, and we are ready to go. I am Dr. Dana Gibbs. I'm an ENT doctor um, who recently retired from my practice. And a lot of what I'm going to tell you guys, I learned through personal experience. So I'm now an expert in Hashimoto's disease. Um, I started out with ENT and then an allergy fellowship. And I started treating thyroid problems, with ENT for about 20 years ago. So as my knowledge grew, I started helping patients with their non-surgical thyroid disease, their Hashimoto's, and then other hormone imbalances as well. I now work exclusively treating people who need help with their hormones, adrenals, sex hormones, other endocrine problems, who have not really gotten ideal results with standard treatments. And then I also proctor a really deep dive course for physicians who want to learn all this stuff, along with my mentor, who is Dr. Alan McDaniel. Anyway, so we are going to talk about thyroid, and I want to give you guys just a little review and overview before we get into the ways that thyroid labs can present and mislead. So all in all, even if only 1 in 5 of the people who have thyroid disease are undiagnosed or improperly managed, that's 10 million people in the US alone. So many of these people are not being treated, or they're not being fully restored to their health, and they're dissatisfied with their results. And these are the patients that I want to focus on today. Patients who have been told that there's nothing wrong with them, or who are put on thyroid medicine, told that everything looks good, but they still feel terrible. All right, so I am not an endocrinologist. I think that's kind of a good thing because I was not indoctrinated into the mainstream medicine way of doing things. So current mainstream thyroid management evolved from tests and treatments that were invented many decades ago from data that was available at the time. It takes on average 17 years for new medical research to reach everyday medical practice. And some of the information that I'm going to refer to in this talk is now 20 years old in the literature. So in my medical training, we generally kind of learn an unconventional, just do what works kind of attitude. And I really do apply that mentality in my current practice. And a lot of this is because it's personal to me, because I personally went undiagnosed all through my teens and 20s. And I didn't even know that what I had was a thyroid problem until I was completely out of residency and had been out in private practice for several years. And I was one of the ones who was completely failed by the current methods of evaluating and treating thyroid, and it nearly cost me my career. So while I'm happy to see alternative medicine shifting back towards the mainstream with a bigger focus on nutrition in particular, I'm really shocked by the magnitude of quackery and misinformation that's available out on the internet today. And unfortunately, that's where the patients are going when what we offer them isn't helping them feel better. So before we talk about what normal TSH means and doesn't mean, I want to back up just a little bit. So first of all, when you examine somebody's thyroid, a palpable thyroid gland is not normal. It's never normal. And just because you can't feel it doesn't mean that automatically it's functioning properly. And in people who are overweight, a lot of the time you can't feel it, period. And there are diseases of thyroid hormone metabolism where nothing is actually wrong with the thyroid gland itself. What? Okay. So what we were taught about in medical school about thyroid physiology is incomplete. So I'm going to start with a review. So the thyroid gland releases T4 and T3 into the bloodstream. 90% of that is T4. That's the pre-hormone. It's stable for storage and transport and circulation in the bloodstream. And then the T3, which is the active form, is about 10% of what's circulating. And that actually is what stimulates your metabolism, your tissue growth, your brain function, etc. And the number refers to that number of iodine molecules that's attached to the basic molecular structure. T4 has 4, T3 has had one of them taken back off again. So most of the T3 that your body needs to function is actually converted from T4 to T3 in the body tissues that need it, which is basically almost all of them. All right, so how do we regulate thyroid hormone? So the brain, hypothalamus, and the pituitary gland together regulate thyroid hormone production. Most of us have seen or maybe remember a slide like this. This is pretty laughable because it makes the pituitary gland look like it's as big as a man's scrotum, which just makes me laugh. But anyway, so the brain measures the thyroid hormones in the blood, and when they're low, the pituitary releases TSH into the blood, and the TSH stimulates the thyroid to produce more hormones. Simple, right? Well, wait, not so fast. So we're going to discuss why measuring only TSH and free T4 maybe doesn't actually tell us how the whole system is functioning. So a little bit of history. Back in the 1870s, when anesthesia was first invented and sterile technique finally allowed surgeons to remove giant goiters, they started doing this. And postoperatively, these people now completely lacking thyroid glands became cold and sluggish and mentally impaired, which is called cretinism. That's a pretty profound hypothyroid. And they eventually died until scientists figured out that they could give these patients thyroid glands from animals and they would completely recover. And at the time, the word hormones hadn't even been invented yet. So back when Synthroid was invented in the 1950s, it wasn't known that the thyroid gland made only about 20% of the T3 that we need and that the body could convert T4 to T3 inside the cells. So when that discovery was made, then it was assumed that this would always happen and that we could just give T4 with impunity and the body would make all we needed. So doctors at that point almost unanimously switched to giving people levothyroxine or T4 to their hypothyroid patients. It was also thought that measuring T3, measuring the TSH immunoassay, which was first invented in the 1970s, would always tell us when a patient had enough thyroid hormone because it's a simple feedback loop, right? Well, no. So the modern tests that we have today weren't even available or invented at this point. And unfortunately, most doctors still monitor thyroid function by only measuring TSH and sometimes T4, or they may still be ordering the T3 resin uptake test, which is an obsolete calculated estimate of thyroid binding globulin and hopefully a percentage of T3, and then the FTI, free thyroxine index, which is also a calculated estimate of T4. And it's kind of weird because those are the tests that are still on the LabCorp comprehensive thyroid panel. Anyway, so not having enough thyroid hormone, particularly T3, or the right balance of the thyroid hormones, results in symptoms of hypothyroidism. So once again, still a review. Thyroid hormones set the rate of our metabolism, the way our body makes and uses energy. Hi, Amy. Happy to see you here. So thyroid hormone helps control metabolic rate, the utilization of energy by the body. It stimulates growth and development, brain development, bone growth, maturation of organs and tissues, particularly in utero and in infancy and childhood. And it regulates your heart rate and the output of your heart. It controls your body temperature, stimulates GI tract activity, maintains function of your nervous system, regulates reproduction, and maintenance of skin and hair, among other things. All right, so here's where almost all of our educations about thyroid stopped. So let's look at T4 and T3 and how you get from one to another. So all the hormones start as T4, which is bound to the long chain thyroid binding globulin and stored in the thyroid. And then to get T3, you have to strip off one of the iodine molecules. So on T3, it's the one that is farthest away from the nitrogen moiety. And then that removal process is performed by a group of 3 enzymes called 5' deiodinase enzymes. And so while 10% of the circulating thyroid hormone is T3, most of the T3 that's produced in the peripheral tissues is produced by intracellular 5' deiodinase type 2 after the T4 is released from thyroid binding globulin and diffuses into your body cells. And the rapidity of this reaction is actually controlled by the amount of T4 that's circulating in the blood, free T4 anyway. So the higher the T4, the faster the reaction runs, and the faster the deiodinase 2 enzyme gets inactivated. And the name of that process is ubiquitination. I can barely say that. So it's kind of a fail-safe for the runaway elevated T4 to not make too much T3, except that ubiquitination does not occur in the hypothalamus or pituitary as quickly as it does everywhere else. So the T3 levels are higher in those tissues in response to T4 as they are in the tissues. So the net effect of this is that the TSH will drop and restore the normal balance of T4 and T3 while protecting the rest of the body from getting too much T3. So deiodinase number 2 is the most active, and it's found to be responsible for more like 70 to 80% of the circulating T3 and most of the peripheral conversion as well in the thyroid gland and the CNS and the skeletal muscle. All right, so the next deiodinase enzyme, the type 3 deiodinase, also removes an iodine molecule, but we get something called reverse T3. So reverse T3 chemical structure is almost exactly like T3, except that the wrong quote unquote iodine is removed. And reverse T3, if it's mentioned at all, is occasionally discussed in the literature as an inactive metabolite of T4. And so most doctors, if they've heard of reverse T3, were taught that it has no activity in the body. It's just a way of getting rid of excess T4. And unfortunately, it turns out that this is not the case. So an analogy would be, think of, have you ever had a key made and it was made just a little bit wrong? So it fits in the lock, but it won't turn the lock. So this is like that for T3. So reverse T3 is so similar to T3 that it still binds that nuclear thyroid receptor. But once it binds, it sits there and doesn't do anything but block the receptor binding sites. So it's actually a competitive inhibitor. You remember your chemistry, competitive inhibitor of the reaction of active T3, because once blocked, the T3 cannot bind that receptor site. And ordinarily, the amount of reverse T3 is only about 1% of the total thyroid hormone. So T3 being 9%, T4 being about 90%. So reverse T3, 1%. And if it gets higher than that, it starts downregulating your metabolism, even if you have adequate amounts of T3 circulating in the blood. So the regulation of thyroid metabolism is much more elegant than we were taught and much harder to spoof. And so you can see why it might be important for the body to regulate this beyond just what's the T4 level. It's a fail-safe in case of thyroiditis or tumors or Graves' disease that make you have high T4, or in the case of iodine insufficiency, which is low T4, or famine or illness, when it's important to slow the metabolism down. So it's a second fail-safe mechanism. All right, so there is a third type, deiodinase type 1, and this one is actually a switch hitter. It can make either T3 or reverse T3, and it really seems to play a pretty minor regulatory role, and it's primarily found in the thyroid, pituitary, liver, and kidney, and it probably produces around 30% of the circulating T3, but not a lot of peripheral conversion. All right, and there are a lot of ways that type 2 deiodinase, which is our main producer of T3, that can get dysfunctional or inactivated. And these happens, if these happen, then type 3 deiodinase tends to be more dominant, and then you get a higher percentage of reverse T3 and a slower metabolism. All right, so what are the symptoms of inadequate thyroid function in the body? I told you guys I was going to go through all the kooky ones that I've seen. So when the cells of our bodies get too little energy, they cannot do their jobs well. So you get fatigue, sluggishness, poor quality sleep, which results in not feeling rested despite adequate or even excessive sleep. Sometimes, not always, weight gain in excess of calorie consumption. Feeling cold or icy, aching hands and feet. I know this one very, very well. Mental impairment with memory and learning problems. This tends to get worse when you get into menopause because of changes in the binding proteins, which lower the thyroid hormones even more. Thin, dry hair and scalp hair loss. Those are very, very common. So I'm going to just go through some more. So thyroid nodules or enlargement or goiter, pale skin, puffy face, wrists and ankles, frequent infections, poor immune function, headaches, muscle aches, joint stiffness, inflammatory joint diseases. Carpal tunnel, Dupuytren's contracture, trigger finger. I would say 30% of the people I see with these problems have carpal tunnel. And frozen shoulder turns out to be pretty common as well. That frozen shoulder I had back 10 years ago, and that was even after I was already being treated for thyroid. And then I do know a person who actually had their colon removed because of profound constipation, because thyroid problems went undiagnosed, and she was worked up at more than one very prestigious medical center, and they did not figure it out. High cholesterol, dyslipidemia, flaky, slow-growing fingernails, depression. And then I mentioned immune problems. So people are hyper prone to allergy problems, including chronic hives, urticaria, chronic itching. And some of them are even experiencing anergy if you test them for allergy. The loss of the lateral eyebrow hair is a pretty interesting sign. A lot of people don't realize that. And then slow heart rate or palpitations, either one. And then some ENT symptoms, dizziness, including vertigo without any obvious cause, hearing loss, irregular menstrual cycles and difficulty with conception, or frequent first trimester miscarriages, commonly causing infertility. And then the death rate is significantly increased. And then, as Amy mentioned, a 12% increase in dementia for every 6 months of undiagnosed hypothyroidism. That's shocking. Anyway, so the causes of hypothyroidism. So number one is the immune system, Hashimoto's disease, or less commonly Graves' disease. So the immune system makes antibodies and inflammatory cells that can destroy the thyroid gland over time, as though it was a transplanted organ being rejected. So the hormone levels go up as the hormone is spilled from the damaged gland into the bloodstream, and then down. How common is this? A CDC study showed 15% of Americans have some degree of autoimmune thyroiditis. So as I mentioned, that's just a freaking huge number. So that is diagnosed frequently with elevated thyroglobulin antibody, thyroid peroxidase antibody, or both. And it's somewhat of the case there. It's now thought that the elevated antibodies are really just collateral damage, and that the real damage is done through the cellular processes, lymphocytes, Hürthle cells, and then you end up with thyroid nodules that are not tumors because the healing process as the disease waxes and wanes results in bands of scar tissue. And then when the thyroid tries to regrow to replace the function that's lost, then it results in these nodules. So Hashimoto's disease will remit about 50% of the time without any treatment, but it very, very frequently progresses slowly to hypothyroidism. Graves' disease is a different kind of antibody that stimulates the thyroid to make too much thyroid hormone. So it stimulates the TSH receptor, and it can cause thyrotoxic crisis, heart side effects of too much thyroid hormone, antibody and amyloid deposition in the extraocular muscles, and the periorbital tissues, and in the peripheral tissues as well. Most people who have that, eventually their thyroid will burn out and result in hypothyroidism, but many people are treated with radioactive iodine or surgery and end up pretty much instantly hypothyroid. So low iodine, more and more people are choosing not to eat salt, or at least not iodized salt. Low iodine is pretty rampant in the US. I mean, the reason iodized salt was invented in the first place was to try to prevent goiters. Low iodine can be checked with an overnight urine test. Mostly this doesn't give frank, obvious hypothyroidism, but it really can produce very, very large goiters. You can also test to see if people are taking too much iodine, because taking high levels of iodine can trigger Hashimoto's as well. So I saw a patient one time who was a bodybuilder and came in with a goiter, and it turned out she had been painting herself with betadine so she would look tan for her bodybuilding competition. And her free T3 was like 2.5, and she was frankly in thyrotoxic crisis. She did not take my recommendations to stop painting herself with iodine, and when she stops using that, she will likely end up hypothyroid. Rarely, tumors of the pituitary gland will cause hypothyroidism, and I was not personally involved, but I know somebody who was involved in a lawsuit because a White Tower endocrinologist saw a patient with very low TSH accuse the naturopath of giving the patient Armour thyroid and causing them to have Graves' disease. This patient was then given radioactive iodine, which destroyed her thyroid gland. And when it still did not fix her low TSH, she finally got a CT scan. The radiologist's report was unchanged size of pituitary tumor. So it's like, damn, that was a big miss. Anyway, so there's other diseases of thyroid that may or may not cause hypothyroidism or hyperthyroidism, which are benign tumors. Anyway, so let's get to what I actually brought you here to teach you. So now that we've caught up on thyroid physiology that you got never taught, let's dive into the meat of things. So 3 variations of hypothyroidism that I see. The first one is low T4 and elevated TSH. So this is the regular type of hypothyroidism. So the T3 will also be low, but of course, most doctors are not even checking that. And this is what eventually happens in Hashimoto's disease when the gland is replaced by scar tissue. And many people will become symptomatic way before their TSH and their thyroid hormones fall out of that standard reference range that's thought to be normal, because the reference range published by the lab is actually way too large. All right, so the next one is low T3 with normal T4 and normal TSH. So this is subclinical hypothyroidism. The TSH may be mildly elevated or not elevated at all. So below 10 probably. And subclinical ought to be called sublaboratory, because having low T3 causes people to have symptoms. And so if you don't test for T3, you miss this one. And it can have a variety of causes, including high T4 levels that push down T3 production in the body cells, but not in the pituitary gland, like we mentioned a little earlier. So their TSH can be normal while the cells are being starved of T3. And this can happen even if the type 2 deiodinase enzyme is functioning normally. We'll talk more about that in just a second. But it also happens when people are given T4 thyroid replacement. All right, so there's also many ways that the main deiodinase can get dysfunctional or downregulated. So the first one is a SNP, a gene abnormality of deiodinase type 2. It's called THR92ALA-DIO2. Don't expect y'all to remember that, but it's a gene variant that's associated with insulin resistance and increased body mass index. And that was actually first found over 20 years ago, 20 years. And it's been found to be more sensitive to being switched off by low to normal TSH and to produce 30% less T3 than the normal gene, even when the TSH is normal. So when they did studies about this in mice and even in humans, even if the T3 range is normal, they sleep more, they exercise less, and they have slow learning. And humans with this abnormality have been shown to do less well when treated with levothyroxine than on a combination. And then there are more recently discovered gene abnormalities that are currently being researched. All right, so let's go on to number 3. So elevated reverse T3 with or without low T3. And with normal TSH and T4. So this is the next type of patient who will have symptoms without an abnormal TSH, and their T3 and T4 can be in the normal range and along with the TSH, and they will still feel symptomatic. So in some people, for a variety of reasons, their cells use the T4 and make high levels of reverse T3 instead of T3 through the action of the deiodinase type 3 that we talked about before. And the more T4 that they have, the more reverse T3 they will make. And we talked about there being blockage of the T3 receptors, preventing the action of T3. So no matter whether you have a normal T3 level or not, the higher the reverse T3, the worse the patient is going to feel. So these last two types will generally have completely normal TSH and are not generally found on any of the usual thyroid tests that most doctors run. And they're the main reason why so many people who have low thyroid symptoms don't get diagnosed. Or they get told that their thyroid medicine is actually working fine. Go away, here, take this antidepressant. Ask me how I know. Anyway, so let's talk a little bit about the different triggers for this elevated reverse T3 thing. So we talked about the gene abnormalities already, and that is really actually a lot more common than people think. It's 15% of British descent, people that have this. So anyway, the next one is stress. High levels of stress, including psychological stress, prolonged stress, calorie-restricted diets, hypothermia, severe illnesses, social isolation, sleep deprivation. All of these stressors our primitive brains see as a survival threat and it shoots your cortisol up, which activates all of these mechanisms that I've been talking about. The next one is too much T4 for whatever reason. Over supplementation with T4 is probably a super common one. But this is also the problem in Hashimoto's disease because the disease fluctuates. The attack happens, it releases all this T4, the levels go way up, and then they gradually go down. So most people with Hashimoto's disease are actually undiagnosed or sometimes improperly diagnosed as having Graves' disease. And so a lot of times these are not a problem with the thyroid gland itself. And so when this reverse T3 is high, we name that non-thyroidal illness, or euthyroid 6 syndrome, which is best described in ICU patients who are really, really ill, but happens in people who are not in the ICU as well. Now, it is not the case that healthy people have no reverse T3 at all. We talked before about it existing in this approximately 10-to-1 ratio of T3 over RT3 in normal folks. So this ratio was really finely controlled by our bodies as a defense mechanism against the effects of diseases that cause these high levels of T4. And that fact is actually helpful because it gives us a clue as to how we're going to monitor and measure T3 and reverse T3. All right, so let's talk really quick about levothyroxine. So T4 or thyroxine is the storage form of thyroid hormone in your body. It's made and stored in your follicles and bound by proteins in our bodies and circulates bound to those proteins. Inside your thyroid gland, you have enough of this to last a few months, even if you were to make no new hormone at all. So unfortunately, the T4 levothyroxine that's given as a medication is free T4. It's not protein bound. And it is cleared by the kidney much quicker than what we were led to believe in med school. As a matter of fact, I hear bandied about that the half-life of T4 is 2 weeks, and that is complete hogwash. So actually at the time Synthroid was licensed, which was back in the 1950s, it was never FDA approved for some reason. So they did not do pharmacokinetic studies to show what the half-life actually is. But in the experience of myself and some of the other folks that do these techniques, if you check labs on patients throughout the day, early, right after the T4 is given, and then midday, and then late in the day, what you see is that the level goes really high and then gradually really low, depending on what time of day you check the lab. So there's no way that half-life is 2 weeks. And those large fluctuations in T4 levels trigger more inactivation of deiodinase 2 and more conversion to reverse T3. All right, here's another thing about levothyroxine, is that cheap generic levothyroxine is sometimes even contaminated with reverse T3 because the FDA doesn't regulate reverse T3 since they think it's inactive and does nothing. So giving T4, also we showed a couple reasons why giving T4 to someone who already has elevated reverse T3 can make their problem even worse because then they make even more reverse T3. So the bottom line here is that measuring TSH in someone who's already taking levothyroxine or any kind of T4 doesn't tell you anything about how much T3 the person has. And studies showed that 15% have low T3, and these are people who are given levothyroxine, and a large proportion of the people have low normal T3, and I feel like those normal ranges as published are way too broad. Anyway, all right, so let's look at labs. And what are we going to do for these people, or what do I do for these people? So these ideal numbers that I've put here, in parentheses, that's somebody who's not already taking medication. And the main one are for somebody who's on thyroid replacement. So these reference ranges are really broad, and the ideal ranges are quite narrow. And I'm going to go through them one at a time. So T4, remember, is the storage form of the thyroid hormone. We already talked about what can happen if you have too much. So the ideal tends to be right down at the bottom of the normal range, which is in some labs 0.8 to 0.8 to 1.7, or I've seen as low as 0.6. Anyway, I like 0.7, okay. I don't like it to be a whole lot higher than that. So 0.8 is pretty good for somebody who's on thyroid replacement. If you're not, it can be as high as 1.3, and as long as the rest of the numbers are okay, I'm not going to fuss about it. Free T3 does need to be pretty tight. The normal range is 2 to 4.4 in a lot of labs. I really don't see anybody who feels well at 2. And most of them, if it's below 2.9, they don't feel well. I don't like to see it up at 4.5 either, but right in the middle of the normal range is pretty darn good. So total T3. So the reason we need to test total T3 is a little bit complicated. We need it to compare it to the reverse T3. We don't really need it on its own. Thyroid hormones circulate in our blood bound to proteins. And in our modern labs, we can order free hormone or total hormone for the T4 and for the T3. And I actually recommend that T4 only be done with free T4. But the amount of these proteins varies. The carrier proteins vary so much from person to person and from month to month that these total numbers have a really broad range and aren't super useful on their own. But since free thyroid hormones tend to be only about 1/100th of the total hormone level, and then free reverse T3 would then be below the detection limit for the immunoassays that we generally use because it's only 1% of the total T4. I'm sorry, total T3, total reverse T3 would be 1% of T4, and free reverse T3 would be 10,000 times less than what a total T4 would be. So there's no test for it. It's below the detection limit. So the reverse T3 test that's available is total reverse T3, even though they don't tell you that. So since the amounts of proteins that bind thyroid vary, the best way to know what's going on with reverse T3 is actually to compare it to the total T3. And when I check reverse T3, if I see it down below 8, that means I have suppressed their T4 too much. If I see it above 16, I know that they're going to have a poor ratio and that they're not going to generally feel well. So I use this as a ratio. So I take the total T3, divide by the reverse T3, and get this nice ratio. And the lowest I like to see it really is about 10. The highest is about 14, although teenagers can go up to 16, and I'm not worried about them. Because this is the 10 to 1, that's the ratio that's present in normal people. And I will say here that you're not going to find this information in any textbook. This is based on clinical observation and doing the calculations over and over again. So you could do a fancy calculation to try avoid measuring total T3, but then you have to know the albumin and the thyroid binding globulin and some other proteins, and it would still only be an estimate instead of the exact ratio because these two do bind the same proteins. All right, one more. So when you check TSH in somebody who's not taking thyroid medicines, it seems okay for the TSH to go up as high as maybe 2.0 or maybe 2.5, as long as everything else is looking completely fine and they feel fine. But once they're in treatment, it doesn't really actually matter. And probably their TSH is going to go down. And I like to see it down below 1, maybe 0.9, 0.8, as low as 0.5 T4, and not down to the lower detection limit of TSH. I do not measure the T3 resin uptake, the free thyroxine index, or the total T4. These are completely not needed. I do test at least once for every patient that comes in the thyroid peroxidase antibody, the thyroid globulin antibody, and sometimes the TSI, or the thyroid stimulating immunoglobulin, in a patient with symptoms who hasn't been tested for Graves' disease before. All right, so what do we do with these folks if we find abnormal labs? So first of all, I do all 5 of those tests that I showed you, plus the calculation of total over reverse T3 every time I test them. And generally 6 weeks again after every time I change their medicine. So if you get numbers you don't like the first time they come in, there's 3 things that you can do. So if they aren't on anything, you can start with tiny doses of liothyronine twice a day, and then gradually increase this until the reverse T3 starts to fall down into the 9-8 range, and then add back the T4 to keep it in that ideal range, because too little reverse T3 is not good either, and people won't feel well. But the amount of T4 that you have to give back will be a lot less than you think. And I generally will start people with 12.5 micrograms twice a day. If they're not, if they're on levothyroxine or some combination that isn't giving them good numbers and relief, the first thing I ask people to do before I even send them to the lab is I have them divide their dose, take a Q12 hours, and do that for a couple of weeks. Then go in and have them do their labs. And I don't check a trough and I don't check a peak. When I check the labs is exactly 6 hours after the morning dose. So then what I'm looking for is 0.8 to 1 for the free T4 if they're taking it Q12. But most people who come in on meds are on way too much T4. Why is this so important? Well, we kind of talked about the fluctuations of T4. Don't people need more thyroid in the morning? Well, yes, sort of. But the fluctuation really matters. And the ideal physiologic way to get it would be in 24 tiny pills that they take 1 every hour all day long, or a pump like an insulin pump. But of course, we don't have that. So twice a day or 3 times a day is better and gives less large fluctuations than your once a day. So this is the case for T3 with its 6-hour half-life, but also for T4 for the reasons that I discussed up above. And then once the reverse T3 is up and the T3 is maybe coming down, I'm sorry, and the T4, I should have said T4, I'm sorry, and the T4 is coming down, it can really take weeks to months for the reverse T3 signaling to calm down and let the reverse T3 start to drop. And so I tend to switch people over gradually with a 5-to-1 switch. So 1 microgram of liothyronine for every 5 micrograms of T4 that I take away. And I do that every month until they're down where I want them to be. And once somebody's on treatment, they really do need to be super consistent about what time of day they take their lab draws. And again, I prefer that mid-dose rather than a peak or a trough. All right. So what do I treat with? Well, I can tell you exactly, because this isn't officially CME, that I really do like a combination of 2 different medications, the levothyroxine T4 and the liothyronine T3. So sustained release T3 does not seem to work. It doesn't really stretch the time of release out. It just reduces the amount that they're getting. We can also use natural desiccated thyroid, Armour NP. I do tend to treat with that. These are a combination product of T4 and T3 in a 4-to-1 ratio. I do not let the pharmacy substitute manufacturers. Whenever they get something cheaper, and they're going to want to try to do this. So I always put brand necessary, and I always specify Cytomel brand liothyronine is super duper expensive. And so I almost always write for the Sigma generic when I'm writing for liothyronine. Within the natural desiccated, if you specify which brand, your pharmacy should not be substituting, because each of these are their own brand name. And all of these medications, particularly the T3s and the T4s, if they're manufactured overseas, are notorious for being contaminated or for not containing the level of active ingredient that they're supposed to. The minimum standard with the FDA is actually 80% to 125% of what's displayed on the label. So even being legal, they can have a 50% difference. So I really do try to very hard to stick with one proven manufacturer brand name in any individual patient. As I mentioned, the synthetic T3s are even worse than the T4. But surprisingly, the natural desiccated thyroids manufacturers seem to actually be doing pretty well on keeping their ingredients really consistent, although their shelf life tends to be short and they are more easily ruined by heat. Think wet warehouses or hot trucks when they're transporting them. So the other thing about natural desiccated thyroid is that it is that fixed ratio of 4:1, T4 to T3. So for some people, it's not enough T3 relative to the T4. And it's also not okay for somebody with a pork allergy or a strong preference not to eat pork or consume pork. So as I mentioned, sustained release T3 from a compounding pharmacy really just seems to lower the amount of T3 that they're getting rather than stretch it out. I personally have never offered that to my patients. And so that's not my personal experience, but my mentors. And some proponents say, oh, we'll just up the dose if you use this, but I'm not convinced that that's going to actually help. I still want it given twice a day. All right. So what is a T3 spike? The endocrinologists are all about the T3 spikes, and they're very, very nervous about giving people T3 because of it. So in some cases, adjustments to the T3 medication dose or changes in the regimen can lead to a transient kind of an over responsiveness to the T3 levels. For example, if they haven't had any in a really long time, they may have a lot of T3 receptors. And so you give them a tiny bit and it results in this T3 spike, which is high levels of symptoms. Or if they get an acute exacerbation of their Hashimoto's, then they can get a sudden release of T3 and that can cause a T3 spike. But the most common reasons for that would be taking too much T3 all at once or too quickly. And then factitious thyrotoxicosis, when people are abusing or misusing thyroid hormone medication, often for the purpose of weight loss, or maybe they are not taking their Cytomel, so their Graves' disease is out of control. Abnormally high T3 levels are going to lead to what they call a T3 spike. This can cause bone loss and heart damage. It's not recommended at all. So you can see why it's important to really be careful. There are actually some thyroid support supplements that people can buy over the counter that contain T3 because the FDA doesn't regulate whether this is present in supplements, and you cannot know how much they've got. And then certain medical conditions like certain types of thyroid cancer, conditions that affect the pituitary gland or the hypothalamus, can cause abnormal fluctuations in thyroid hormone levels as well. But the most common reasons are these that I have listed. So the first one is that most patients who are first given T3 have been trying to stay awake desperately by taking lots and lots of caffeine. And so you give them T3 and all of a sudden they really respond to caffeine. And so you have to get them off caffeine as you raise their T3 level. The next one is high insulin levels. So if somebody has insulin resistance, they will have the tendency to go hypoglycemic. This will give them a giant boost of adrenaline, and they will feel like they're having a T spike. And then the final one is adrenal insufficiency, which if you speed up the metabolism of somebody who can't make enough cortisol, then they will also spike adrenaline and feel really, really terrible. And T3 is getting the blame in that case as well. All right, so symptoms of too much T3, I'm going to run through these really, really fast. You've seen now how the symptoms of elevated T4 can actually be just the opposite of these. So if they're making reverse T3 and not T3, so these are particularly seen in people with elevated T3. So irritability is often the first symptom that you see when a patient's T3 level gets too high. And then unexplained weight loss, despite an increased appetite or normal appetite, is a common symptom. Rapid heartbeat due to elevated thyroid hormone levels, tachycardia, palpitations, and irregular rhythms. Heat intolerance, people with hyperthyroidism often feel excessively warm and sweat excessively as well, even in cooler environments. Nervousness and anxiety, restlessness are common, and then fine tremors in the hands, fatigue and muscle weakness. Despite having increased metabolism, they may get muscle weakness and fatigue, and I think that's probably the adrenal insufficiency. Then bowel habit changes, hyperthyroidism can cause diarrhea, sleep disturbances, difficulty falling asleep, difficulty staying asleep, hot flashes, and then changes in menstrual patterns, lighter or irregular menstrual periods or shorter menstrual cycles. And then Graves' disease. So I'll just give you guys an example of this. So I have a patient who has Graves' disease that I'm treating now. And her reverse T3, the last time I checked, was in the 40s. It was ridiculously high. And so how I'm treating her, how I'm supposed to be treating her, is by giving her, excuse me, and my brain, my menopausal brain, methimazole. And then when her T4 gets down, then I replace her T3. The last time I got labs on her, her T4 and her T3 are up even higher. So my suspicion is that she is skipping her methimazole because she likes the fact that she's keeping her weight off by having those high levels. Unfortunately, it is very bad for your heart, and that is not advisable. And if she doesn't get better about taking her methimazole, I may have to ask her to go find another doctor. Toxic goiter from iodine can cause high T3 levels, and then thyroid cancer as well. And so that's basically all I've got for you guys. That was a lot. I'm sorry. When I teach this to the public, this is what I tell them. Thyroid hormones are prescription only. If you don't have enough thyroid hormone, there's not really a great alternative to taking prescription medicine. So these thyroid support supplements that a lot of non-physicians are touting on the internet contain unregulated amounts of T3 and can be damaging to your normal thyroid if you actually have a normal thyroid. People need to see a physician who's knowledgeable and does more than just check TSH. And if they're not sure, then they need to have their doctor reach out to me and I will help them figure it out. They need to check all the labs that I mentioned. And unfortunately, there's not really a thyroid panel unless you custom make one in your EMR. A comprehensive thyroid panel at LabCorp will not get what you need. And you need to find somebody who's going to prescribe T3 replacement. So anyway, that's all I've got. I do, Juliana, you mentioned some more basic information. I do a lot on the internet. I have a live that I do every week that has a slightly less dense version of this talk. And if you want to go on my patient mailing list, I can add you. I'm happy to add you. You can either send me an email or this QR code leads to that, and then you will get tagged to receive the patient newsletter, which has links to all these lives that I do. And that's it. So I'm going to stop the share. And who has questions? I see we lost some people, but I ran long, so not terribly surprising.
So do you have a private practice or like a consulting practice or what?
Yes. So yeah, I have a consulting practice in Texas. I can see patients virtually from Texas or from Iowa. And I also can do coaching. So like, for example, if a physician from another state wants to see me personally or have me advise them personally, I do some coaching in that way, but I have not coached a patient who is out of where my medical licensure is. I don't
Okay.
know how that would work exactly, except I do have a much more detailed than that. You think this was detailed? Holy cow. I have a much more detailed physician course that is almost 6 hours of thyroid content, among other topics. We do insulin resistance, we do female and male sex hormones, we do adrenal fatigue, we do vitamin D and other supplements. And I would love to bring people into that. It's all recorded and on Zoom. Unfortunately, right now, I don't have CME for that. I am working on getting CME for that, hopefully soon, because I think a lot more people will be willing to spend the time and effort to do it. I mean, it's over 20 hours worth of material. So yeah, it's pretty overwhelming. But yeah, my practice is consultants in metabolism, and patients can request appointments or even a discovery call on the website. And the website is also my name. It's easier to remember, danagibbsmd.com. And yeah, and happy to, if you have a patient you want to discuss with me and you're like, I want to try this. I have actually 2 psychiatrists in our discussion group already who do really, really well. And yeah, happy to have you if you're interested. All right, so one of the comments is somebody who got a traumatic brain injury and ended up with central hypothyroidism. Wow. Yeah, I guess brain injury can damage and destroy your thyroid and cause empty cell loss. So that would do it. Yeah, Juliana, do you have more specific questions or something I can
Yeah, I just have
go
2
back
more
to
questions.
and make it? Yeah, let's hear it.
I have 2 more questions. Is there
Sure.
any kind of fee to be in the discussion group, and when is that?
Yeah, so the discussion group does have a fee. I don't charge a lot for it, but it costs me money to run it because of the website and the email lists and all the things that go with it. I charge $29 a month for that. If you sign up for the course, 6 months of the discussion group is included in the course sign up fee right now. And I am working on hopefully making this series into something that's a little more digestible than the big course, which is not actually taught by me, it's taught by my mentor. So if you guys like this and you think, wow, I should slow it down and spread it out and use more examples and things, then that's really great feedback. And I'm happy to keep working on that, because I would love to have this be something that all doctors know about instead of it just being me.
Thank you.
What else? What else have you, do you have another question?
No, thank you.
All right. Jennifer, Rita, Andrea, any questions that you guys have for me? If not, I'm going to go ahead and sign off.